For a case of ankle pain, using our mnemonic old cards, we'll note the onset, or when did your pain start? Did it come on suddenly, or was it more gradual? And do you remember what you were doing at the time? For the location, we'll ask our patient to point with one finger. As we've been seeing with all of our extremity cases, the location alone often gives us a differential. For the duration, we'll ask our patient if the pain has been constant since it started, or if it's occurring more intermittently. If that's the case, we'd like to note the frequency. That is, how long does an episode of your ankle pain last for, and how many episodes have you been having per day or per week? Next, we'll want to note the progression. Does your pain appear to be occurring more frequently or more severely? Or if there has been no progression, we'll also want to state that in our patient note to show we've asked. To help characterize the pain, we'd like some descriptors, sharp or dull among others, and since it can involve the nerves as we'll see below, we'll ask about any numbness, tingling, or motor weakness, aggravating and alleviating factors, radiation, treatments tried, and severity on a scale of 1 to 10. And again, if there are no aggravating and alleviating factors or radiation, we'll also want to state that in our patient note to show we've asked. We'll break down our case of ankle pain into traumatic and atraumatic causes. For all cases, let's order a CBC, serum electrolytes, an X-ray of the right or left ankle, an MRI of the right or left ankle, and if we find any neuropathy, as we'll see above, a nerve conduction study and an electromyogram. In an ankle sprain, the pathology is involving the talofibular ligaments. Our supporting points will include ankle pain, an onset that's sudden after trauma. A patient can describe rolling their ankle, and will be alleviated by conservative management. RICE, rest, ice, compression, elevation, and NSAIDs. We'll find a decreased range of motion as we do for all of our traumatic cases, and we can note positive special test for talar tilt as we'll see coming up in our physical exam. In an ankle fracture, we'll find ankle pain. The onset too will be sudden after a trauma. Since the fracture can involve the underlying nerves, we could note a neuropathy or numbness, tingling, sensory loss, or a motor weakness, and we'll find now limited relief by conservative management because the underlying fracture has yet to be fixed. The fracture could also be producing pain at night or nocturnal pain, and we'll find a decreased range of motion. In osteoarthritis or degenerative joint disease, DJD, we'll see ankle pain, an onset now that's more gradual, but progressively worsening. It will be characterized as dull or achy, and classically, it's aggravated with use, alleviated with rest, and seen in an older patient. As with all lower extremities, obesity from the added weight could increase the risk. In an Achilles tendonitis, the chronic form, or an Achilles rupture seen acutely, will find ankle pain and now posterior, so we see the importance of the location. The onset will be after suddenly running, jumping in the chronic form, and accompanied with a characteristic popping in the acute form. In the chronic form, it will be alleviated by conservative management, RICE plus NSAIDs, and in an acute rupture, it may not be. Also in a rupture, as we'll see in our physical exam, we'll note a positive calf squeeze, also known as a Thompson test. In tarsal tunnel syndrome, the pathology here is tibial nerve compression. We'll see ankle pain and now medially. We'll also find a neuropathy, or a numbness, tingling, sensory loss, and motor weakness. It will be aggravated by standing and alleviated by orthotics, which help open up the tarsal tunnel. If the patient described trying orthotics from a friend or maybe the store. And interestingly, orthotics is also the first-line treatment that we can help counsel or explain to our patient. And also a history of risk factors, prior foot trauma or surgery, and it will be a positive Tinel test. In rheumatoid arthritis, we'll see ankle pain, and it will be aggravated in the morning, high-yield morning stiffness, and classically alleviated with use. We'll also find additional bilateral small joint arthritis in the wrist or fingers, and we can note systemic symptoms in our review of symptoms, fatigue, fever, or weight loss. We could also find a positive family history. We'll add to our workup an ESR-CRP, rheumatoid factor, and anti-CCP antibodies. In systemic lupus erythematosus, we'll see ankle pain, a malar rash, oral ulcers. Our patient will also be complaining of photosensitivity or Raynaud's, blue fingers in the cold or times of stress, and we could also find the systemic symptoms in our review of symptoms, fatigue, fever, or weight loss, and a history of abortions in our OB-GYN history. We'll order ESR-CRP, ANA, anti-double-stranded DNA antibodies, and anti-Smith antibodies. In crystal arthritis, we'll see ankle pain, and now in our inspection and palpation, we'll note an erythema, swelling, and warmth. In gout, we could find podagra, or in the big toe, in tophi, crystal deposits in the ear or behind the Achilles, and a history of heavy drinking or diuretic use. And in the pseudogout form, our patient is typically older with a history of a recent trigger, surgery, or medical illness. We'll order an ESR-CRP, an arthrocentesis with gram stain, culture, and microscopy, and a serum uric acid level. And finally, in septic arthritis, we'll find ankle pain, and now with fever and our vital signs, and an inspection on palpation will note an erythema, swelling, warmth, and it can be also given to us by bandages in the physical exam. And in the gonococcal form, it's classically seen in a female because they're asymptomatic gonococcal carriers. We could also see the finding of the pastular rash and a history of STDs or multiple sexual partners. And in the non-gonococcal Staph aureus or strep, there will be a history of skin trauma, abrasion or cuts, diabetes, or IV drug use. And in addition to our arthrocentesis, we'll order blood cultures.
So, welcome back. We're going to do a physical examination of the ankle joints and of the heel. Okay. So, as usual, I'm going to start by sanitizing my hand. Remember, in your exam, it's always good to wash your hands. You can wear a glove. You sanitize your hands. Maintain proper hygiene. If you sanitize your hands, don't touch the patient until it's dry. My hands are dry now. So, Mr. Herskowitz, you mentioned that you had a pain. Where did you have this pain?
My right ankle.
Okay. So I'm going to do the examination. All right. So now I'm going to just inspect the front, the medial aspect, the lateral aspect, and the posterior aspect. I don't see any swellings, any redness, any visible lesions anywhere. Okay. And I'm going to compare it with the other ankle. I'm going to do the same. I'm going to look at the dorsum of the foot. I'm going to look at the plantar aspect of the foot. Again, no lesions, no redness, no swellings. Okay, so then I'm going to palpate afterwards. So let me know when you feel pain, okay?
Okay. Oh, right there.
Okay. I'm sorry. Now, a rule of thumb is, if a patient tells you they have pain somewhere, you don't want to start palpating at that spot. Example, this patient has pain in his right ankle. I want to start and palpate the left, and then go into the right around the areas and end up there, and see if he has a tenderness. That's a good way to approach it. So, but in the interest of time, I'm just going to do one limb. You say you feel pain around here, right?
Yes.
Okay, sorry about that. So I'm done with the palpation, and just assume that I did on the other ankle as well. So time for range of motion. Just assume my hand is your foot. Just do what I do, okay? Can you tilt it upwards? Okay, flex it. Okay, extend, go like this. Now, can you tilt? Okay, the other way. Can you try to invert and evert? Okay, good. You want to compare with both feet, not just one. So you're going to have them do it with both feet, and you're going to compare, see which one is performing better, you know, which one is not doing as well. All right, so that's the range of motion. I can go ahead and also check the muscle strength. So in this situation, I'll just go ahead and do both. Can you just kick up? Just, yes. Okay. So there's more strength on the left than the right. Can you push down the brakes? Again, more muscle strength on the left than the right. 5 out of 5, about 4 out of 5. I just checked S1 and S2. Okay. Then, because I've done the joint, the ankle joint, I want to check the knee joint. I'm going up. I want to just quickly sanitize again, wash my hands. I don't want to take any germs from his feet upwards. My hands are dry. So I'm going to just quickly inspect. No lesions, no redness. I'm going to do real quick. Palpate. You feel any pain?
No.
Any pain behind here?
No.
Okay. Can you do this? Extend. All right, flex. Excellent. All right. So, kick out against. Okay. Kick against. Now, pull. Yes. 5 out of 5 muscle strength on both sides. So, the range of motion is done. Joint above. Okay. I'm also going to look at the phalanges as well. And we've done the muscle strength. Okay. So in this situation, you can have the patient lay down, you can have them sitting down, whichever works for you. So I'm going to bring out my hammer. Can you close your eyes for me, please? You feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Sharp.
You feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Soft.
You feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Soft.
You feel that?
Yes.
You feel that?
Yes.
Same on both sides?
Yes.
Sharp or soft?
Sharp.
Okay. So I've checked for sensation. Now, in a patient who has diabetic neuropathy, they would not feel or just feel very little in their feet. Another way to do it is get a tuning fork, strike it for the vibration and place it. We're just going to assume this is a tuning fork. So close your eyes, please. You feel the vibration?
No.
Okay. You strike again and you compare. What do you feel? You feel any vibration?
Yes.
Okay. Another way of checking for that is the toe position. Okay, it checks for, because patients who have diabetic neuropathy lose their proprioception because the dorsal columns are affected. So I'll have him close his eyes. Your toe, is it up or down?
I'm not sure, doctor.
Okay. Is your toe up or down? Up. So that's how to check for positional sense or proprioception. And that is basically the sensation of the lower limb. I'm going to check for reflexes. So just relax, please. Swing, swing. Okay? 2. I'm going to do it on the other side as well. Okay? So 2 plus. All right. So if you're doing this and you're going to do sensation, it is not complete without a Babinski reflex. So with Babinski, you want to go from here this way, and you're going to see him curl the toes. This is normal, a negative Babinski. In a patient with, nerve damage, and even normally with babies, they're going to have the opposite effect where they're going to fan out their toes if you do the same Babinski. So I'm going to go ahead and check for the pulses. Popliteal, I can feel it a little bit. Dorsalis pedis, both sides, compare, which I can feel. Excuse me, this is a posterior tibial, not dorsalis pedis. This right here is a dorsalis pedis, which I can also feel. I'm going to have a quick look at his toes. Can you do this with your toes? Can you call them? Can you do the same? Okay. So I've checked for pulses, I've checked Babinski, I've checked everything. So now it's time to do certain special tests. I'm going to do the tilt test, where I'm going to move his foot around, which you're going to see. I'm going to tilt the posterior aspect. I'm going to help him invert and evert, and I'm going to lay him down and do a test called the Windlass Test. So I'm going to help him. Any pain?
A little bit.
Any pain? I'm
Yes.
trying to evert. Okay, so I'm Holding the calcaneal bone intact. You feel any pain?
Yes.
Okay. You feel?
Yes.
Like this? Okay. Again, I'm pushing inwards and outwards. Any pain?
No.
All right. Can you lay down for me, please?
Yes.
Okay. Time to check the plantar area of his foot by doing the Windlass test. You want to do a Windlass test if you're concerned the patient has plantar fasciitis. So the way you do it is you have him stay like this, you isolate the foot, you dorsiflex the toe, especially the big toe, and with one finger you want to press right here and ask the patient if he feels any pain. Do you feel any pain?
Yes.
Okay. I'm going to repeat it here on the left. Do you feel any pain?
No.
Okay. And that is the Windlass test. Finally, I'm going to check for gaits. I'm going to see how he walks. For example, if a patient has a foreign object retention in the leg or plantar fasciitis, they can limp. So I want to assess to see how his gait is going to be. So please, can you let me help you up?
Thank you.
All right. So I'm going to have him walk from here and back. Sorry, you need any help? Any support?
No, I'm okay.
Okay.
Just don't put too much pressure on this side.
Okay. I'm sorry. Okay. So you can see he limps. So you can sit back down. I'm going to end this by asking if he has any questions for me.
Doctor, do you think I'll be able to walk again?
Based on the history and physical examination today, I feel that you told me earlier you were diabetic and you couldn't really feel in that foot. I think it's most likely diabetic neuropathy, which just means that, when you have excessive blood sugar, sometimes it can affect your nerves and doesn't make you feel as much on that area. So we're just going to conduct a couple of tests. I'm going to have a look at the sugar, and we're going to, try to make sure your sugar is under control. Okay, and try and rule out other causes of that. Okay, if we are able to act well, yes, you'll maintain the full use of your leg and your foot. Okay.
Thank you.
All right. Very nice to meet you, Mr. Herskowitz. And that ends the exam.